All right, it looks like the number of attendees has just about leveled off, so we'll get started. My name is Vin. I'm a fifth year MD PhD candidate here at U of T, and I'm one of the learner co-leads in the education theme here at T-CAIREM. So today we have a really exciting trainee round session for you all, and it just so happens that our two talks today fall nicely within the theme of vascular surgery. So for those of you with a special interest in cardiac, vascular surgery, surgery in general, you're in the perfect place to join us over the lunch hour. So we'll have two talks today and some time in between for questions. And how we'll do questions is I'll ask that you please either write in the chat and I'll call on you to say your question or just read it aloud if you prefer that I do that. Or otherwise just raise your hand and I'll call on you to ask your question that way. So to start off, we'll hear a talk from Dr. Ben Lee. Ben Lee is a vascular surgery resident PhD candidate here at U of T. His thesis focuses on using machine learning to predict outcomes following major vascular surgery. He works collaboratively with data scientists, researchers, and clinicians to apply ML techniques to healthcare with the goal of improving patient care. Ben is excited to share his work with you, and we're really excited to hear about Ben's work. So Ben, over to you.
Thanks, Ben, and thanks to T-CAIREM for the opportunity to present our work with you today. Can you let me share screen?
Go ahead.
Thank you. So like Ben mentioned, the focus of our work today was on machine learning in vascular surgery. And we specifically conducted a systematic review and critical appraisal. And I'm really excited to share this work with you guys today. As you know, ML is a rapidly advancing field with increasing utility in healthcare. And I think it's very applicable to our specialty, vascular surgery, for several reasons. First, many procedures in our specialty are now performed using endovascular technology with CT-guided imaging. And this allows for the use of strong ML-based imaging analysis techniques to improve data analytics in our specialty and improve care for our patients. Second, there are objective definitions for many vascular conditions. For example, we define AAAs as any abdominal aortic aneurysms that are greater than 3 centimeters on imaging technique. And so this allows for automated diagnosis using ML techniques. Third, many of our procedures are high risk and many patients develop complications as a result of the procedures that we perform. And so I think that also provides opportunity for us to improve outcomes for patients by using ML-based prediction techniques for us to better identify which patients may benefit from surgery and what kind of surgery we should be doing for these patients based on these ML prediction algorithms. And finally, there's a growing abundance of patient-level data through large vascular surgery registries. And as you know, large and diverse data sets are critical to building strong ML algorithms. So in the research setting, ML algorithms have been applied to vascular surgery in a few different ways to predict abdominal aortic aneurysm growth, to diagnose carotid artery disease using things like carotid Doppler waveforms, and to identify patients with peripheral artery disease who have a high risk of mortality. But despite this, translation to real-world practice remains limited. And to date, synthesis and quality assessment of the ML literature in vascular surgery has not been performed, which I think is a critical first step to better understanding how we can apply ML techniques to vascular surgery in a clinically applicable way. So our goal in this study was to conduct a systematic review and critical appraisal to synthesize and evaluate the ML literature in vascular surgery. We conducted a systematic review according to PRISMA statement guidelines, and we registered our protocol prospectively with Prospero. We devised our search strategy with a librarian. We searched 3 databases, MEDLINE, Embase, and Cochrane, up to March 2021. And we included all original studies reporting ML applications in vascular surgery. We used a combination of mesh terms, keywords, and synonyms for ML and vascular surgery to maximize sensitivity. We looked through the reference list of included articles and we hand searched them for additional relevant articles. And we used Google Translate for any non-English studies. We performed article screening, data collection, and assessment of risk of bias and reporting adherence with 2 independent reviewers, with a 3rd author resolving discrepancies. And again, we included all original studies reporting ML applications in vascular surgery. We excluded reviews, commentaries, editorials. We collected data using a standardized form based on the CHARMS checklist. And we contacted authors for any relevant information that was not reported in the original publication. We plotted publication trends in 5-year intervals. We developed bar graphs to summarize the number of papers focused on the different vascular conditions, the ML models applied, and their study design. We summarized outcomes, including area under the curve, sensitivity, and specificity, using means and ranges across included studies. And then we performed critical appraisal for each study using 2 tools. The first was the PROBAST tool, which determines the study's overall risk of bias using 20 methodology questions. And the second was a tripod tool, which determines adherence to reporting standards for predictive modeling studies using a 31-item checklist. And here's what we found. So this was a Prisma study flow diagram. So from our database search of 3,100 articles, after removing duplicates, we reviewed 2,200 unique articles, and we excluded 1,600 through title and abstract screening. We assessed 575 through full text review, and we excluded 363 from that, mainly because either there's no machine learning technique or there's no relevant vascular condition. So in total, we included 212 studies in our systematic review and critical appraisal. So this was our publication trend over time. And as you can see, the first published study applying ML to vascular surgery was in 1991. And since then, there's been increasing interest in this topic with more and more publications. And between 2016 and 2021, there were 118 publications on this topic. And authors looked at a variety of different vascular conditions. Major ones were carotid stenosis, aortic aneurysm, and dissection, and peripheral artery disease. And diseases that were less well studied in ML were also less well studied in vascular surgery in general. For example, diabetic foot ulcer, venous disease, and renal artery disease. And studies looked at a variety of different topics, including diagnosis, prognosis, and image segmentation. So some examples of how people applied ML to vascular surgery were detecting aortic aneurysms and dissection on imaging, like ultrasound, CT, and MRI, determining the degree of carotid stenosis using Doppler waveforms, diagnosing vascular disease and grading the severity of disease using clinical data, image segmentation of images of diabetic foot ulcers to identify areas of infection in non-healing tissue, and to predict things like aneurysm growth rates, progression of vascular disease, and adverse events in healthcare utilization following surgery. In terms of the study design, most studies were retrospective and used single-center data. Some studies use either multi-center, registry, or a public database. And only 5 studies included some kind of prospective design in their study of ML in vascular surgery. In terms of the ML models applied, most authors applied the neural network, but there is a range of different ML models, including support vector machine, fuzzy classifier, Bayesian model, ensemble model, among others. In terms of the input features for ML model development, most studies used imaging or Doppler signals as the sole input feature. 41 studies used structured clinical, laboratory, and genomics data alone. 16 used structured and imaging data. 3 used clinical notes alone, and 2 used both structured variables and clinical notes. And so only a minority of studies used both structured data and unstructured data, which again is a major advantage of ML-based techniques. External validation was performed again in a minor studies, 4.2%. In terms of the median area under the curve, we looked at this for each vascular condition, and it was quite good. Most of the areas in the curve ranged from 0.8 to 0.9 for each condition. So the median area under the curve for all included studies was 0.88 with a range between 0.61 to 1. 22 of these studies compared ML models to either clinicians, risk prediction tools, or traditional regression. 22 performed better, 2 performed similarly, and none performed worse. And in terms of the percentage of studies with outcome values that were greater than 80%, for area under the curve, this was 79%. For sensitivity, this was 80%, specificity was 85%, and accuracy was 92%. And this was the first tool we used for our risk of bias analysis. This was the PROBAST tool. And it looks at risk of bias in 4 domains in each study. So it looks at the participants, predictors, outcomes, and analysis, and it judges the study's overall risk of bias. And in order for a study to score a low overall risk of bias, it must score low in each 4 of these domains. And green is low risk, yellow is unclear, and red is high risk. So as you can see in the overall column, almost all of the studies applying ML to vascular surgery were deemed by this PROBAST tool to be at high risk of bias. And so when we looked at this risk of bias analysis, we looked at each of these domains and the reason why these studies were deemed to be at high risk of bias. So 84% of articles were deemed high risk in the analysis domain. And this is because they either did not report the number of participants with missing data, perform calibration to assess model performance, or account for overfitting. 45% of articles were high risk in the participants domain. This is mainly because they did not describe the inclusion and exclusion criteria for their participants. 47% were high risk in the outcomes domain. And this was mainly because outcomes were not defined or the time interval between prediction and outcome was not reported. 38% of articles are high risk in the predictors domain, and this was because of inadequate definition of predictors and unclear availability of predictor data at the time of model application. We looked at risk of bias over time in 10-year intervals, and you can see a slight improvement with a little bit more green over time. And low-risk articles overall, so the green in the overall column, were only published in the past decade. But even you can see between 2011 to 2021, still the majority of articles were high risk. So still a lot more work to do. There's just 4 studies I'd like to point out that we judge to be at overall low risk of bias. The first is Perkins, published in 2020, and they used US registry data to develop a naive Bayes model that predicted amputation risk following revascularization surgery. And they externally validated this algorithm on a UK registry, and they achieved an area under the curve of 0.97. Ross in 2016 applied decision trees to detect peripheral artery disease and predict mortality risk using a combination of clinical, imaging, and genomics data with better accuracy than logistic regression. Ravo in 2021, this was supervised by Dr. Rosella here at T-CAIREM. They used Ontario administrative health data, including over 1.5 million patients and 700 clinical variables to predict diabetes complications. And Ross in 2019 used electronic health records data, including both clinical data and clinical notes, to predict adverse cardiovascular events in patients with peripheral artery disease. So some of the underlying strengths that were common to all 4 of these studies were they appropriately defined their study population, predictors, and outcomes. They reported discrimination performance and model calibration, and they provided supplementary data to let readers know how they can actually apply these models to their own practice. So this is a second way we critically appraise the studies using the tripod tool, which looks at adherence to reporting standards in 31 domains of the study. So including things like their title, abstract, study design, up to their predictors, outcomes, and then their interpretation of the results. And they looked at whether each of these sections of the paper adhered to reporting standards. So I can see for some areas, this was very good. So there's over 90% reporting adherence in things like the rationale, objectives, and interpretation. But for other areas, there is less than 3% reporting adherence in sample size calculation, missing data handling, and model assessment. And for some areas that I thought were critical to studies like the participants' inclusion and exclusion criteria, the participants' characteristics, and how to actually use the model in our own practice, this is only reported about 20% of the time. So overall, adherence to reporting standards was about 41% in all of the studies. And again, we looked at this over time in 10-year intervals, and there was a slight improvement from 37% to 43% adherence, but again, still a significant amount of work to do. So in conclusion, through this study, I think we've identified that many studies have applied ML technology to vascular surgery within the research setting, and they have achieved excellent discriminatory value with a median area in the curve of 0.88. We believe that ML technology can provide powerful augmentation to clinicians for image analysis, disease diagnosis, and outcome prediction. However, risk of bias and adherence to reporting guidelines are currently substandard, likely due to the novelty of the field. Low quality evidence is a barrier to translation to real-world practice, and ML algorithms should be rigorously validated prior to clinical implementation. And based on this study, what we recommended was that future studies should consider standardized tools such as PROBAST and Tripod to guide ML study design and reporting to improve study quality and clinical applicability. Thanks very much for your time.
Thanks very much, Ben, for a fantastic talk. We now have about 10 minutes for questions, and I see that Jay has raised his hand. So Jay, why don't you go ahead and ask your question?
Sure. Thanks for the presentation. It's really interesting. I have two questions regarding data selection and ML model selection. Regarding the studies, I guess in one of the slides you presented, majority of them were kind of retrospective studies and some were prospective. In your opinion, is there any particular preference that some data is kind of more accurate than the other?
Yeah, so I think we definitely need to use retrospective data in building ML models because that gives us, a large diverse data set and lots of information to build strong ML models on. But I think it's also critical that we're able to prospectively validate these models in the clinical setting. So I think the lack of prospective studies, I think, is probably a reflection of both the novelty of the field and the fact that a lot of the times once these algorithms are developed, they're left on the table and they're not actually translated into clinical practice, which I think is a significant barrier. So I think I'd like to see more prospective studies in the future.
Okay, yeah, sounds good. And regarding the ML model selection, I've seen most of the authors have used neural networks. In terms of real world application, have you encountered any pushback in terms of choosing neural networks or other tree-based model? I mean, in theory, we were kind of told that the tree-based model, there's some sort of transparency that we know the mathematics behind it versus neural networks that we really don't know that based on what algorithm it came to that conclusion. So is there any, in real world scenarios, any pushback for implementing neural network models?
Yeah, thanks. That's an excellent question. I think because we haven't had a ML model that's been used kind of widespread throughout vascular surgery, it's difficult to say whether people prefer neural networks or other types of ML modeling. But I think clinicians, whether in vascular surgery or any other field of medicine, they like to have models that they can understand and have clinical explainability, so that when the model makes a prediction or makes a diagnosis, they can understand what went on behind that prediction. And obviously there's a lot of criticism about ML and neural networks and that they're black boxes. So I think there's still a lot of work to do. There's a fine line between kind of making sure that we achieve explainability, and also that the model performance is optimized. So I think we're still trying to figure that out, at least in our specialty and other specialties of medicine as well.
Okay, sounds good. Thanks, Ben.
Thanks, Jay.
So our next question comes from Sunil. I don't see your hand raised, so I'll just go ahead and read your question. What factors contributed to the decrease in overall risk of bias over time?
Yeah, so I think the decrease in the analysis domain. So more studies would kind of report how much missing data was in their study, where that missing data came from. They better define their patient population, so they describe their inclusion and exclusion criteria. They used more metrics to validate their ML models, and I think for those reasons, studies became lower risk of bias over time, as people kind of became more comfortable in knowing how to apply ML modeling in a clinical setting.
And just a quick follow-up to that, I think systematic reviews play a very important role in surveying the field and trying to understand where researchers are at in terms of best practices. Do you think journal editors, I know, for example, the vascular surgery journals, the editors are very active in terms of writing editorials and posting on social media. Do you think it would make sense for editors to put out a statement saying, hey, we know this is a very popular up and coming research area. We stand by the use of these checklists for all submitted publications to our journal to make sure that researchers are adhering to these best practices?
Yeah, I think that'd be a fantastic idea. It would be important that we, select the right checklists, and that we standardize, reporting in the right way. I think there's a lot of different kind of tools out there, and making sure that we select ones that are validated and standardizing this across studies, I think would be amazing. And I think this would improve the quality of the work in the field. Especially
once the updated tripod and PROBAST checklists for AI specifically come out, which will hopefully be soon. So our next question came in from the chat from Dr. Howe. Ben, can you comment on the clinical variables that are most useful or most reliable? Do you have any insights about how multimodal ML models and how you can select the correct number of clinical variables, plus or minus lab values, genomics, imaging?
Yeah, so I think multimodal ML models that consider both structured data, things like patients' demographics, specific clinical variables, and also unstructured data, for example, imaging data, clinical notes using natural language processing techniques, are the ones that perform the best. So I think, when authors or researchers are developing ML models, I think they should strongly consider not only using things like databases, which give structured information, but also including unstructured data. And through the systematic review and through my review of the literature, it's these multimodal models that include these different types of information that have clinical relevance to patients that are the most powerful. Thanks for that question, Dr. Howe.
So our next question comes from Rashmi. I see that you have your hand raised, so go ahead and unmute yourself.
Awesome, thank you. Great job, Ben. It's really nice to see surgical residents working in ML and AI, and I'm sure that you and I will continue to cross paths. I think that this point was brought up earlier, and maybe we can expand on it. So now there's this whole space now of people coming up with checklists. So if you go on the Equator network, which is kind of the where I go when I'm looking for these checklists, I just right now quickly just typed in machine learning and AI, and there's 8 checklists, and there's Jack has its own checklist and somebody else has their own checklist and the next person has their own checklist. And I mean, the checklist, to be frank, there are a lot of things that are in common with them, but it comes down to your point, like which one do we use? And it also makes, I think from a publication standpoint, actually it creates barriers because, you know, you go from one journal to the next journal, you got to create a whole new checklist and you got to be maybe doing some sort of different analysis to keep up with that checklist. And so this, I think that there needs to be a better way. What do you propose? Like, how do you think we should go about this?
Yeah, I agree. I think it's a tough point in finding a balance between, you know, picking the right checklist and making sure they're not burdensome on authors and researchers. You know, I think one way that we could do this, for example, in vascular surgery, we have the Society for Vascular Surgery, and they make you know, guidelines, clinical guidelines on you know, how to treat patients and also how to do research. And so I think maybe standardizing that through bodies like that, and for example, the Society of Vascular Surgery kind of decides on this kind of checklist is most relevant to our specialty, or even modify those checklists so that they're specifically relevant to the specialty, because I think every specialty has their nuances, I think would be one way of doing it. But yeah, I agree. I think it's challenging when every journal uses a different checklist. So I think it's important that we kind of develop evidence that shows which checklists are most validated and most useful and most clinically relevant, and we choose those checklists.
Yeah, I totally agree. I think the other dimension to it is like, what is the task? You know, is it an imaging task versus unstructured data versus clinical data? Because I think your checklist is going to look different based on what the actual ML AI task is. Great job. Thank you.
Thanks, Rashmi.
And finally, Arun, please go ahead and ask your question.
Thank you, Ben. I work in palliative care, but I'm interested in the AI part of the stuff. So my question is that, so what databases did you search for the systematic review? Apologies, you might have kind of covered it. Might be a redundant question in that case.
Yeah, thanks, Arun. We searched MEDLINE, Embase, and Cochrane, which are the major clinical databases.
Okay, so because AI AI papers also come in computer science journals, is there any other database if you want to capture the literature from the engineering part of it and not much from the medical part of it?
Yeah, we actually captured, I think, close to half of our studies were actually engineering-based studies. So there a large proportion of engineering journals are indexed in these three databases. So we captured quite a few engineering articles, but I agree, you know, these are the databases that we have expertise in. But I agree with you that, you know, future studies should consider more engineering databases as well. Thanks for that point.
No, thank you. And the next part is that, so in the protocol, have you guys, went ahead and published the study or the protocol for this one?
Yes, the study was published in Nature Digital Medicine just earlier this month. Yeah, earlier this year.
Oh, awesome! Congratulations on that. Yeah, thank you very much.
Thanks, Arun.
Thanks so much to Ben for once again an amazing talk and discussion. I went ahead and dropped a link to your paper in the chat in case anyone wants to take a look. Great work. Congratulations on getting this out and published. And if anyone has any other questions, I encourage you to reach out to Ben and his team. I'm sure they'd be more than happy to connect and chat about their work further. So next up, we have Nitish Bhatt. So Mr. Bhatt is entering his second year of medical school, also at U of T. He previously completed his undergrad studies in systems design engineering at the University of Waterloo. He's very interested in and eager to explore applications of AI to medical imaging. Also, we can see your slides in presenter view. There we go.
Okay, great. Thank you very much. So like was mentioned, I'm Nitish. I'm a second year medical student at the University of Toronto. Extremely excited to have this opportunity, and thank you for providing this platform. I personally learned a lot from the previous talk as well. So today I'm really eager to talk about some of our work regarding the use of deep learning for automated classification of plaques in carotid ultrasound. So carotid plaque develops within the carotid arteries, which are major blood vessels that supply the face, the neck, and very importantly, the brain. And as these atherosclerotic plaques build up, in some cases, they can become unstable and rupture, leading to, in some cases, devastating consequences such as stroke. For that reason, assessing the presence, progression, and possible instability in these carotid plaques is important for the treatment and management of patients with carotid artery disease. Unstable plaques can produce sometimes symptoms such as vision impairment or mini strokes, and like I mentioned, in other cases can produce major events such as ischemic stroke. However, only a small minority of these plaques go on to become unstable and cause clinical symptoms or major events. And for that reason, surgical intervention is typically prioritized for patients with unstable plaques because the surgery itself has a risk of causing stroke. And for that reason, selection of patients that have symptomatic or unstable plaques, it's important. But making this determination can be challenging because it can require accurate knowledge of the patient's clinical history, and it can require expertise on the part of the healthcare provider. And in some cases, it's only possible to know that a plaque is unstable when the patient has already experienced a major event. So carotid ultrasound imaging is a mainstay of investigation for carotid artery disease. It's non-invasive, it's relatively inexpensive, and it's routinely used to follow patients with known or suspected disease. As most of us know, deep learning has shown potential clinical utility for a wide variety of medical image analysis tasks, including carotid ultrasound. However, previous methods have relied on either some form of manual pre-processing or manual expert image level annotations as shown in Figure 2. These are expensive and time consuming to generate, as well as potentially prone to inter-observer variability. And a fully automated method using deep learning to classify plaque presence, progression, and potential instability in carotid ultrasound hasn't been well established. So for these reasons, we're aiming to develop fully automated deep learning models that analyze carotid ultrasound using only longitudinal B mode or grayscale images for 3 binary classification tasks. Firstly, we want to be able to detect carotid plaques, that is to simply classify no plaque versus plaque. Secondly, we want to be able to detect biologically relevant plaques. It's often moderate to severe plaques that cause stenoses and are commonly implicated in symptomatic patients. So it's important to differentiate between patients who have no plaque or perhaps mild plaque from those that have more suspect moderate to severe plaque. And finally, we want to identify instability and using imaging alone differentiate asymptomatic versus symptomatic plaques. So in terms of our study, we've included healthy controls as well as patients with carotid disease. The patients were categorized by the severity of the carotid disease using an accredited vascular lab criteria at UHN. There were 3 categories per plaque severity. There was no plaque, mild plaque, and moderate to severe plaque. Furthermore, patients that were categorized into the moderate to severe plaque group, we performed chart review in order to determine their symptom status. So they were further classified as asymptomatic versus symptomatic. We excluded patients that had incomplete or unreadable imaging, and any images that contained an unmodifiable image annotation like an arrow or text within the image field itself were also excluded. This resulted in a final data set that contained 75 images with no plaque, 82 images with mild plaque, 75 images with moderate to severe asymptomatic plaque, and 64 images with moderate to severe symptomatic plaque. So in terms of our method, our deep learning method makes use of a type of model known as a convolutional neural network, or a CNN. And very briefly, CNNs take an input image and through a series of convolution and pooling operations, extract an increasing number of increasingly abstract features, leading to a final deep feature vector, which is then forwarded to a classifier to obtain the model's predicted output. Since we're dealing with binary classification tasks, we will get a single output, which will be a binary positive or a negative output relating to whichever task we're training for. So it could be the presence of plaque, progression of plaque, or instability in plaque. Okay, so on this slide, we're aiming to illustrate the training procedure for the deep learning method. So our fully automated method starts with a automated pre-processing step where we use thresholding and morphological operations in order to automatically crop the image field. The images are then partitioned into training and testing subsets. So the training subset will be used in order to train and develop our model, whereas the testing subset will be reserved or held out for evaluation, as we'll discuss in the next slide. But firstly, the training subset was used in order to train an ensemble of 5 convolutional neural networks. These were ResNet 50 architectures that were used, and they were trained using a stratified 5-fold cross-validation technique. So this technique, what it does is it takes the training subset and divides it into 5 data folds, each containing an equal number of positive and negative samples. 4 of those data folds are used to train the network, and 1 is used to validate the network, that is, to evaluate the network's performance after every training epoch. We iterate through the data folds such that each fold is used for validation exactly once, and this will allow us to get an ensemble of 5 CNNs that are trained on different portions of our training data set. We also then take these 5 CNN models and freeze or fix the network's weights and use these CNNs then as feature extractors to extract deep features from samples in our training data set. These deep features are concatenated or combined into a final deep feature vector, which is used to train a classifier, which predicts the output, positive or negative. Here we're aiming to illustrate our testing procedure. So for testing, we can go back to the data partition step and recall that we had this subset of the data that was reserved or held out, and we'll now use this to evaluate the performance of our network and model. So the samples in the testing set are first forwarded to the 5 CNNs to extract deep features. Those deep features are combined, forwarded to the classifier to obtain a prediction. Predictions are evaluated with respect to the expert labeled truth that we discussed in the dataset slide, and they're evaluated using a few metrics. They are the receiver operating characteristic area under curve, the sensitivity, and the specificity. And for each of these metrics, we calculated the 95% confidence interval using bootstrapping. We also use the predictions in order to generate a saliency map. So saliency maps allow us to interpret the important regions that contributed to the model's prediction. And we generated saliency map using a technique known as GradCam. And the output of these saliency maps will essentially be these heat maps as shown, which can be overlaid on the original image in order to understand which regions contributed to the model's particular prediction in this case. So in a case like this, where there is a plaque, we would want to ensure that the model indeed used region informations in the region of the plaque to make its prediction. So now we can discuss some of the results, and we can start with our first objective, which, if we recall, was simply to differentiate cases that contain plaque from those that contain no plaque. And in order to provide some context, if a human expert were to conduct this task, they would have excellent performance. It's probably easy for them to do. However, our automated method for this task also showed good performance with an ROAUC of 0.9, a sensitivity of 0.98, and a specificity of 0.7. We're also showing the ROC curve, which plots the false positive rate against the true positive rate. A perfect classifier, of course, would have a true positive rate of 1 and a false positive rate of 0. A classifier with no skill that is making predictions based on chance would fall along this identity line, the dotted line. So what we can see is from both the AUC value as well as this ROC curve, this model has considerable skill in classifying the presence of plaque. We're also showing the confusion matrix. So in the confusion matrix, we categorize samples along the rows according to the true label. So in this case, no plaque and plaque, that was labeled by the experts. And along the columns, we are categorizing samples based on the model's predicted output, so positive or negative. And what this confusion matrix is showing us is that the model predicted 65 true positives, 14 true negatives, 1 false negative, and 6 false positives. We think that this is reasonable for this task because we would want to aim to minimize these false negatives as much as possible, because otherwise these plaques would be missed. For the false positives, of course, it's not ideal, but we think that it would prompt further investigation, and the expert clinicians would aim to correlate this information with the clinical findings in order to make any further decisions. So that's kind of the overview of the results. And the other item in this confusion matrix that we've shown is the saliency maps for representative predictions in each one of these 4 categories. So in the true positive category, we can see that not only did the model correctly classify the plaque, but it was focused on the plaque region in order to make that correct assessment. In the true negative case, the model focuses on a segment of the carotid artery, including the lumen of the artery as well as the artery wall, in order to correctly arrive at its decision that there is no plaque present. For the false negative, the model again focuses on a segment of the carotid artery as well as the wall, however, misses the fact that there is a mild plaque present in this image. And finally, for the false positive, it's perhaps quite interesting because the model is focused on a segment of the carotid artery wall. And even though in reality, there is no plaque there, perhaps the model believes that and assesses that there could be some mild plaque present, even though in reality there is not. So for our second objective, we aimed to classify relevant plaques, and that is to separate moderate to severe plaques from those patients who had no plaque and mild plaque. A human expert, to give some context for this kind of a task, would again show good performance. There could be some variability between observers because of different criteria for what constitutes a moderate to severe plaque. But our automated method achieved an excellent ROAUC of 0.94, a sensitivity of 0.93, and a specificity of 0.9. We again show the ROC curves, and from the confusion matrix, we can see there are very few false negatives and false positives. The representative prediction saliency maps show that the model focuses on relevant regions in order to make its assessment. Next, for our third task and objective, which is classifying plaque instability. This is a task that has, as I mentioned earlier, great clinical significance because it could potentially be useful in identifying patients that have unstable plaques and could benefit from intervention. We want to classify asymptomatic versus symptomatic groups within the moderate to severe plaque patients. Currently, using only B-mode ultrasound imaging, it's not feasible and very difficult for human experts to assess which plaques are unstable, which plaques are symptomatic or asymptomatic. Our model in this case achieved an ROAUC of 0.67. However, from the confidence interval, we can see that even the lower bound of the confidence interval is higher than the chance AUC of 0.5. Our model does show some skill with this task, even though the results aren't far from perfect. And again, from the saliency maps, we can check that the model uses relevant information regarding the plaque and the surrounding areas in order to make its assessments. However, we were, of course, wanting to improve our model's performance, so we decided to try another step. What we do in this case is we try to select the most important deep features from our model in order to then train the classifier to make its decision. So this is a schematic that shows the training procedure again, and the training procedure is very similar to what we saw earlier. We have the pre-processing, we have the data partition step, we do the CNN training using the exact same method. However, at this stage where we extract deep features from our training set, combine them, we first perform a lasso regression step. And this lasso regression step will eliminate highly collinear features and select the most important features. So we'll get a classifier in the end that is simpler and more robust. So these are the new results after performing that lasso regression step. Our AUC improved to 0.76, our sensitivity improved to 0.84, and our specificity improved to 0.68. These are the changes in these metrics with respect to the original results presented a couple of slides back. And we also plotted the ROC curves from the original model and the classifier after lasso regression. And what we can see is there's a significant improvement in the AUC value. So in conclusion, this is a really exciting field because ultrasound is non-invasive, it's relatively inexpensive as an imaging modality, and it's already known to be useful for the assessment of carotid plaques. We're aiming to develop a deep learning method that is fully automated to assess the presence, progression, and instability of these carotid plaques. And each of these three parameters is important in the diagnosis and management of patients with carotid artery disease. Particularly important is that our method doesn't require any image level annotations or manual pre-processing, and we think this will make it more easy to scale and will make our model potentially more robust, as sometimes these annotations and manual pre-processing steps, like I mentioned, are susceptible to inter-observer variability. For our next steps, we think that there could be great value in integrating other sources of data in order to create a multimodal model. Things like image radiomics, baseline patient characteristics and risk factors, as well as patient biomarker data can hopefully improve the prediction performance of our model. We also want to apply model interpretability techniques in order to better understand the model's predictions. For example, our third objective of detecting plaque instability using imaging alone, it's quite difficult for experts to perform this task. And perhaps through understanding how the model is able to achieve some skill for this task, we can discover some important features of the imaging that can be used by experts as well. I think it's important to discuss some of the limitations of our current results. We're working with a small data set right now that is retrospectively collected. We're hoping to, moving forward, collect prospective data that can then be used to further validate our model on a larger data set. We have not been able to perform external testing. All of our data is from a single center, and we're looking for data collaborators or open source data that can move us towards externally validating and testing our method. And so far, we've only used one CNN architecture, which is namely the ResNet 50 architecture. We're hoping to experiment with other common CNN architectures in order to obtain a model that hopefully is optimal for the tasks that we're aiming to do. So that's the end of the presentation, but I do want to take a second to say a big thank you to the following individuals, the team that I've had the opportunity to work with for their support, valuable feedback, and mentorship. Thank you so much for this opportunity.
Wonderful. Thanks so much, Nitish, for that great presentation. I see that we do have one question so far from Saman. I'll just read it out. Can you explain if human expert performance was solely based on a physician looking at B-mode ultrasound picture, or if more information was used? Since ultrasound shows 2D view of the lumen, it might miss some plaques, and confirmatory images like CT or angio would completely exclude the presence or extent of the plaque.
Oh, sorry, I'm just going to go back. So when we comment and try to provide some context around what we think the human expert performance would be for each of these tasks, we mean looking only at the B-mode ultrasound images. We recognize that, of course, there's other data sources and imaging modalities that would have better discriminatory power, would have better sensitivity and specificity. But ultrasound is really unique because it's used widely already. It's inexpensive and it is quite, there's no danger to the patient. It's completely non-invasive. There's no radiation, etc. So I think that for those reasons, ultrasound, of course, has its advantages, and we're trying to comment using just the single data source, which is the B-mode ultrasound image. How would a human expert do, and then how would our model do in comparison?
And I think Saman has a follow-up, so go ahead and unmute yourself.
Yeah, thank you so much. Well, actually, the question that I had was, like, let's say with the first study, if there is a plaque or not, and then like when you look at the confusion matrix, especially when you look at the like a false positives rates of the machine learning, like the question that might come to mind is that like maybe like it's outperforming us, and then like maybe because the way that they're identifying the plaques are like not just by watching the presence of a plaque, but the adjacent tissue around that, maybe they're like picking up some signals that's showing some plaques that are on other planes. But like, you know, if a person just looks at this picture, they might miss that. So basically, I think that was the main question that I had. Thanks again. That's a great talk. Thank
you. Yeah, we are really excited by that. I think that's a really important point that highlights the importance of why an automated pipeline is really useful, because the model is learning image features by itself. It's extracting these features by itself. And we want to use better interpretability techniques moving forward to try to understand how it's making some of these decisions. And maybe we can learn something from what the model is learning. And since it's fully automated and we don't have any image level annotations that an expert is performing, there is that possibility to discover something new.
So we got a question in the chat from Kathy. Not sure if I missed this, but what kind of thresholding did you do for your pre-processing?
So the thresholding, there were two steps in the pre-processing. Firstly, there was morphological erasing. So we can see that in this image, there's a lot of these lines that are outside of the ultrasound image field itself. So we wanted to remove those. So we used morphological erasing in order to remove those lines and text. And then it was a simple threshold using Otsu method in order to crop out the image field itself. So nothing sophisticated, just a simple binary threshold.
So I have a question as well. So it looked like your incidence of the different categories is balanced across the 4 categories that you studied in this work. Roughly like 80, they're all between 80 and 60, but does the actual incidence of these different types of disease differ drastically from that in real life? For example, you're also at TGH, right? A hyper-specialized center. So do you think there might be some selection bias in this cohort?
Yeah, it's definitely possible. And that's a really good question. I think that when we try to develop models, we want them to have kind of balanced sensitivity and specificity. But in real life, of course, if we're trying to use this kind of tool for screening, especially, we want to pick up on those low incidence cases. So sensitivity is very important. I think that point also speaks to the importance of external validation on a large cohort collected from multiple centers. And that's something that is a limitation of this results right now, but is a big priority for us moving forward.
Yeah, totally fair. And as a quick follow-up, did you consider any data augmentation? So for example, just flipping your images or changing the, I can't remember the term in ultrasound, but how bright or dark it is, any of these augmentations to actually increase your number of images?
So that's a great question. Thank you. I forgot to mention, during the training of the CNNs, we trained for 200 epochs, And on the fly, we perform data augmentation. So they're randomly applied. There's a set of several augmentations. There's random rotation, as you mentioned. There's random translation. There's also random scaling and flipping, as well as data erasing. So we take random sections of the image and we zero them out, we erase them. And hopefully this will improve the robustness of the training. We didn't do anything in terms of the brightness or the gain of the image itself, because I think that there's information there that we didn't want to mess up, specifically regarding like some of these carotid plaques can be very calcified and they can appear very bright. So we didn't want to change the relative intensities of the images itself.
Totally fair. Thank you for that. Faraz had a question in the chat. What was the reason to select ResNet 50 as your primary CNN architecture of choice? I know you mentioned you're interested in exploring some other ones down the road, but how did you land on ResNet 50 to start?
Right. It's a great question. Thank you for that question. We wanted to use a CNN architecture that was relatively well tested and well established, as well as relatively simple. So there's of course more sophisticated CNN architectures that have more parameters. These architectures can be more prone to overfitting. So I think that it was more of a kind of a judgment call almost, but this was a method that seemed like it was an architecture that seemed like it was well established, but also relatively lightweight compared to more sophisticated CNNs, which in literature might provide more state-of-the-art results, which I fully acknowledge. There's efficient net, there's dense net, which can in literature have been shown to provide better results than something like a ResNet 50, but they're heavier models that might have more weights and might be more prone to overfitting.
Great, thank you for that. And finally, to close this off, I'll let Rashmi ask the last question.
Thank you so much. I mean, I will, full disclosure, I'm like very involved in this study, and I'm super proud of Nitish of what he has accomplished. I think a really important point, and someone touched on this, is that if you look at task 3, to the naked eye, people cannot distinguish symptomatic versus asymptomatic plaque. So if you ask an expert to look at a severe plaque and tell you whether or not that plaque is going to rupture, they can't. And so that AUC of 0.67 is actually a good AUC if you think about it, because it's better than chance. And I wanted to kind of string the two together along with Ben's work, because Ben, you know, when he put his data together, he talked about AUC and talked about how great AUC can be. But I think you have to always keep in mind what it's benchmarked to. And so when Ben was talking about, oh, you know, it's benchmarked to logistic regression, if log-reg sucks and like ML sucks less, but it's not perfect, you're still doing a pretty good job. And so I think that's what's really impressive about this third task. And I think that just kind of being privy to, you know, where Nitish is going with this, I think that there's going to be some knowledge generation that comes out of this, like, you know, like someone said, the peri plaque area and other features that we don't currently look at in the ultrasound imaging are important for us to be considering when we think about patients at risk. Thank you.
Yeah, that's a great point. And, you know, to further emphasize that, I think what was really nice to me about looking at that outcome is that it's fundamentally a patient-reported outcome measure. And when you think about the potential of this kind of work to improve patient care, I mean, it doesn't get any more clear than that.
Absolutely. The label is a great label. You're using a patient-driven label. Totally.
Wonderful. And I hope in the future you guys can consider incorporating patients into the team to talk to them about how you can further refine that. And, you know, there's an easy way to do that, and there's a hard way of doing that with, you know, something like a Delphi process to try and figure out some consensus on what does symptomatic really mean and what is most bothersome to patients. And I hope you guys can pursue that in the future. So thank you everyone once again for attending our vascular surgery themed trainee round session today. We'll post the video on our website as well as on YouTube shortly after the session ends today. Again, if you have any questions, please feel free to reach out to Ben and Nitish they'd be more than happy to chat with you. And thank you again to both of them for presenting such phenomenal work. So we'll see you all again soon. Take care.